Seeing a lot of familiar seeing a lot of familiar faces and names here, which is fantastic. And I'm excited to be back. I have missed you, Charmise, and have missed getting to discuss on Wednesdays. And would love to hear if anybody has a case that they want to present today. We are still open for a case.
While people think about cases they've seen, I just want to I texted Jack after last week's VMR just to say Maddie's hyponatremia discussion would have made him very proud. So I just need to give another shout out to that.
I was Jack, we missed you, but I just channeled your mustache and channeled your hyponatremia schema, and it went well.
There we go. It's a salty mustache, so it makes sense. I love it. I love it. I was beaming with pride when Sharmin texted me that. And I was like, it's time. It's time. All right. We will hold up a little bit longer for a case if anybody has one that they want to present. Doesn't have to be a completed case. Any case is a great case. All right. Well, rest assured, everybody, Maddie comes to the rescue in many ways. Oh, but Alec also is saying that he can pull one out. Alec and Maddie, I will let the two of you duke it out to decide who.
Yeah, who loves sodium more? I'm kidding.
No one is
totally up to you if you have or Mark, you know.
Maddie, I want to hear you present a case because your cases are awesome. So, and if you go back to the repository of like when the VMR started, I presented too many times. So
no such thing, Alec. No such thing.
All right, Maddie, whenever you're ready.
All right. Well, this is a 30-minute VMR, so we'll do this speedy. So let me just pull up my notes on the case. So this is a case of a 38-year-old woman who presented to the emergency department because of left-sided neck swelling and pain. And to give you a little bit more of the HPI, so she said that she was in her normal state of health until around a week ago. She said that she had a sore throat that resolved after a few days, didn't treat the sore throat with anything. It was just kind of self-resolving. But then really in the last 2 days, she started noting this progressive, 2 days of left-sided neck swelling and pain. When we asked about other symptoms, she said it was associated with some jaw discomfort as well as some odynophagia. And it was kind of limiting her ability to eat or drink. She said she last ate 1 day prior. She said this is the first time this has ever happened to her. And really she came in because she was just having a really hard time moving her neck, having a hard time eating, and it was bothering her. So that's why she came in.
Wow, what a start. So maybe what I will do, I'll just talk a little bit more broadly about how I think about like kind of neck masses and swelling, and then just have Jack layer on the rest of the HPI to that. So when I think about a neck swelling and neck pain, and especially if there's like thinking about like whether it's like a mass or swelling, I kind of run through the same schema. And I often think about like, starting with the skin, if there is any like abscesses there. And sometimes like, you can have like other cystic striae, like a dermoid cyst or something, but like kind of abscess within that category is like a no misdiagnosis. There are like some congenital issues like pteroglossal duct cysts and all of those things that can present as masses. Again, that is like diagnosis of exclusion oftentimes. Lymphadenopathies in general can be painful and can cause neck masses. Anything related to thyroid, right, like a goiter, cancer, can lead to a patient perceiving it as a neck mass. The other thing that can happen with the salivary glands in particular, thinking what else is in that space, is like stones or enlargements that can happen. The one category not to forget about are like vascular etiologies. So thinking about any IJ thrombosis, aneurysms that can happen, that also can be perceived as a mass. And then the other structures like, a parathyroid gland can also be on the hook. So that's like kind of my general approach to thinking through neck masses. Jack, what are your thoughts?
I love it. I think that is such a fantastic approach. And I mean, I'll just riff briefly here on sort of some of the other background that we have, which is that this neck mass is occurring in the context of a recent sore throat. And I think there's two ways that we can link the sore throat and the neck mass together. Well, really three ways. One is we could say that they're true and unrelated, right? This person had a sore throat and they have a reason for a neck mass. Another one is to say that the neck mass is a contributor to the development of a sore throat. And if we run through the list of things that Sharmin just taught us about, and we ask ourselves, could we imagine these things causing a sore throat? I think the answer to that question is yes, right? We know, for example, that individuals who have an enlarged thyroid, like a goiter or thyroiditis or Graves' disease, can have pharyngitis as a complication of that process, right? A big, bulky lymphadenopathy within the neck can also cause irritation of the pharynx and give somebody a sore throat. And certainly many of the other things that Sharmin mentioned, like an abscess or something vascular within the neck, can also irritate the throat and cause a pharyngitis. So that's one directionality. The neck mass was growing and that caused the sore throat. The other directionality is that the sore throat has led to the development of the neck mass. In other words, what we're dealing with is a complication of pharyngitis. And when we think about complications of pharyngitis, it can be helpful to have in the back of our minds, what are some of the red flag symptoms of pharyngitis or of a sore throat? And we can break down those sort of warning signs of a sore throat into two primary categories. There can be symptoms of a deep space infection of the neck or the pharynx, and there can be signs of airway obstruction. If we think about signs of deep space infection, right, those will usually signal that the sore throat or the pharyngitis has moved to the more posterior structures, whether that's a paratonsillar abscess, a retropharyngeal abscess, or something down into the vascular structures of the neck, like an internal jugular vein thrombus. Deep space neck infections, we can be cued into the possibility of them if the sore throat becomes unilateral, right? Most times the sore throat's in the back of our neck or in the back of our throat, but if it moves to one side, right, that could be a sign that we're dealing with a deep space infection. If we see overt swelling either in the oropharyngeal cavity or in the neck itself, it could also be a sign. If somebody has trismus, right, which means that it's difficult to open and close their mouth, like what happens when we chew, that could be one sign. Or if someone has severe pain that makes it difficult to swallow. And so if we look at some of the symptoms that she has and say, well, gosh, are any of their features of a deep space neck infection, or are anything that might suggest the possibility of a deep space neck infection here? The answer is yes, right? This is a unilateral thing. There's swelling in a mass and it's difficult to eat. And that difficulty eating could be because it's hard to chew or because it's hard to swallow, right? The other category of symptoms of airway obstruction, we don't necessarily see yet. That's going to be things like if the patient's drooling, if they're short of breath, if they're having stridor, if they're in a sniffing position, which is when they move their head forward like this to open up the airway a little bit more. And then one of the scariest ones, which is a hot potato voice, which is if you've ever taken a bite of a piece of food that's too hot, and you can't talk like this because it's too hot, that's what can happen if somebody has a big obstruction within their airway. And so as Sharmin was saying, right, we can take the framework that Sharmin gave us and say, okay, these are the things that could cause a neck mass. And we have to ask ourselves, was the neck mass there and then came the sore throat? Or did the sore throat come and then came the neck mass? Either way, we have some red flag symptoms here. Thank you for the hot potato voice shout out. Either way, we have some of those red flag symptoms there. And so we're worried about some of the deeper structures of the neck being involved, whether it's the non-infectious things or the infectious things like a retropharyngeal abscess or a paratonsillar abscess.
That was amazing. Wow, what a phenomenal discussion so far. And I can never not laugh when I hear the hot potato voice. All right, so to give a little bit of review of systems, so no weight loss, no chest pain. She said she has had intermittent like shortness of breath since this neck mass has developed. She feels like it's just kind of compressing on like where she's breathing. The rest of review systems is negative. She hasn't noticed any fevers, no night sweats, no rashes, no joint pains. In terms of past medical history, she does not have any known past medical history. It's only notable, I guess, from the chart. She was noted to have poor dentition, and that was also confirmed on physical exam, which I'll get to. No surgical history, no known family history. In terms of social history, she's not currently employed. She lives in a trailer in the area around San Francisco. She has a 10-year tobacco smoking history. She still smokes about a half pack per day. She has a history of smoking fentanyl and methamphetamines, but has not smoked either of those for 1 month. She denies any injection drug use and also does not report any injection drug use in the neck. What else? She does not take any daily medications, has no allergies. So I'll give you the, I saw this patient a little bit later on, but I'll give you the vitals and exam from in the ED. So in the ED, she was febrile to 39.3. Her blood pressure was 102/59, heart rate 105, and she was reported to be somnolent and intermittently hypoxemic to the high 80s. So she was requiring high flow nasal cannula due to desaturations to the high 80s, and then transitioned to 4 to 6 liters of nasal cannula, and then her O2 sat increased to 97%. In general, she was a well-developed adult, though she appeared sleepy. For the HEENT, for the mouth, there was noted poor dentition and she was drooling. There was significant left-sided edema and erythema. No fluctuance was noted. And I actually have a photo that I can show you. Cardiovascular exam, no murmurs, no abnormalities there. Pulmonary, no wheezes, and it was clear to auscultation. Abdominal exam was unremarkable. Extremities showed no rashes or edema. And then neuro, she was noted to be somnolent, but responsive to voice. She was oriented, no focal deficits, and the cranial nerves were intact. So let me show you a photo. I really cropped it to preserve patient privacy, but hopefully you can get a sense. So give me a second. Share screen. Do you mind making me a co-host so I can share the screen?
It should be done.
Okay. Okay. Can you all see this? So just to orient you, I really cropped the photo to preserve her privacy, but of course this is her ear, her nose is this way, and this is the mass, if you can tell, and this is kind of the swelling. And another thing on the exam is she was really kind of unable to move her neck back and forth. She was really feeling that the mass like really limited her ability to move her neck. So I can pause there.
All right. Well, this is, I think, quite the evolution here. I'll just talk briefly about some of the other symptoms that Maddie articulated for us, and a little bit about the past medical, and then we'll leave this juicy physical exam to Sharmiz to think through. I think the big thing that has come out in the history is that she's been feeling a little bit short of breath at times. And I think just to ask ourselves, well, what are some ways that a throat problem can lead to shortness of breath? And I think we can think about this via the upper airways and also via the actual lungs themselves, or actually not just the lungs, but the thoracic cavity, right? So one way that throat problems can cause shortness of breath is through one of the mechanisms that we already articulated, which is airway obstruction. Swelling within the oropharynx or the retropharyngeal space can obstruct the upper airway and cause some of that airway obstruction. But even if the upper airway ends up being clear, there's other ways that throat problems can impact respiratory status. And that occurs through two primary mechanisms. The first is going to be through the bloodstream, and the second is actually going to be through extension of this infection down into the mediastinum. And so even if, right, let's say that as this case unfolds, the upper airway is clear, the shortness of breath does not, the shortness of breath still matters, and it doesn't mean that the lungs are necessarily off the hook, right? We can have things, for example, like an internal jugular vein thrombus that develops from pharyngeal irritation, and that internal jugular vein thrombus can throw emboli to the lungs. And then these retropharyngeal infections in the deep spaces of the head and neck, the layers of fascia in the area behind the pharynx, the deeper areas of fascia have basically an Autobahn highway directly down into the mediastinum. So these infections, if they make it back far enough, can run all the way down into the mediastinum. And if they get back really far, can actually run all the way down the vertebral column. And so the shortness of breath there, particularly in the setting of this poor dentition, right, makes us wonder, oh, are there many microbes in that area that could have set up shop first in the throat and then further back, right? And we see that there's, again, three primary paths to get to the shortness of breath: airway obstruction, vascular involvement through an internal jugular vein thrombus, and then deep tissue involvement with progression of that infection down into the mediastinum.
Yeah, brilliant discussion, Jack. So going through the exam, I'm worried about this patient. So if I'm seeing this patient in the ED, right, she's febrile, she's tachy, she's hypoxemic, and she's somnolent. While we can say, you know, she has history of Matthews, and that is like diagnosis of exclusion, because what I'm worried about is like if she's more hypercarbic, and that's what explains the somnolence. So this is someone that right off the bat, I'm getting a gas and I'm calling anesthesia and ENT to help me evaluate her airway and think about whether this patient, we need to protect her airway and she actually requires intubation. The things to, again, pay attention to, especially like with kind of with the drooling, with this history, with kind of like the swelling that we saw, if it's a mass occupying lesion that is providing some, either like a leading to airway edema, whether it's like more upper or lower, that like ENT can help us with their scoping. And also if, you know, she continues to decline, then like anesthesia should try to intubate as fast as possible to make sure, you know, we stabilize her first while we try to figure out what is causing these issues. And then while we're doing that, then I would say like this is someone that like imaging would be really helpful for. However, you want to stabilize this patient first before we like put her in a CT scanner, right? Because we don't want an airway code or anything to happen in the CT scanner, no matter how fast some of those scans are. The other thing that I really love, Jack mentioned, like the other thing, you know, you want to think about whether someone's hypoxemic, like what's going on with the lung, and the lung sounding normal in this scenario is not reassuring that something that is not going on with the parenchyma. You know, as Jack alluded to, like if she's bacteremic and has septic emboli to the lung, and if she's not moving airway well, because of whatever is happening, you might just not hear what is going on within the lung alveoli. So again, hopefully like stabilizing her, getting imaging, and, you know, our usual lab would be kind of like my first step in trying to triage her.
All right, phenomenal discussion. So I will give you labs and I guess all the data until the final diagnosis for this aliquot. So some initial labs, so they got an EKG, which showed sinus rhythm. In terms of the CBC, the white count was 30,000 with a neutrophil predominance. Hemoglobin was 12.1, platelets were 483, an ESR was 116, lactate 1.1, and venous PCO2 was 55. For imaging, they got an initial chest x-ray that showed right basilar atelectasis, no pleural effusion, pneumothorax. They did note that there was apparent asymmetry of the left neck soft tissues, but were incompletely evaluated. So they got a CT chest and neck, which I can actually also show you. So let me go ahead and share my screen. All right, so just to give you, it was actually the CT scan that helped make the diagnosis. So I can also, I wanted to show you that. So you can really see the swelling here. I can give you a partial read of the CT. Let me see what other how much other details I had. Did you want me to go through kind of what the CT scan showed and everything, or did you want to make any comments?
I'd say no, feel free to go through it. I mean, yeah.
Yeah. So basically from the CT scan that I showed, they commented on sub-Q soft tissue stranding of the left lateral neck and face involving the sublingual, submental, and submandibular spaces, as well as the left posterior occiput associated mass effect of the supraglottic and the laryngeal airway narrowing to 5 millimeters. On the note, it said, like, recommend emergent ENT consultation for high risk of airway compromise. So ENT was involved. They ultimately did a laryngoscopy. She was transferred to the ICU, ended up not needing intubation, but ENT was involved very early on. And then also mentioned on that same CT chest was associated thrombosis of the left internal jugular vein at the exit from the jugular foramen with non-opacification through its distal course, extensive regional lymphadenopathy. They also commented that there was no drainable fluid collections. So blood cultures were collected. They were ultimately negative. An HIV test was negative. She received a dose of Unison in the ED, and then she was started on Zosyn and clindamycin because she had an allergy to vancomycin. And I'll pause there, and then I can talk about how the team was thinking, what the final diagnosis was.
Oh, wow. What a rich aliquot and case. Maddie, can you tell me the ABG again? Sorry, I missed it.
Yes, I apologize. I don't have the full EMR pulled up, so I don't have the whole thing there. I had only written down the PCO2, which was 55. I'm sorry about that. I can pull it up though if you want.
No worries, no worries. I just wanted to get a sense. How about I'll like comment on the labs and then have Jack walk us through his impression of imaging, and then we can go back and forth. In terms of her labs, again, unsurprising that she's quite inflamed, right? Like she has a leukocytosis to the 30s, she has a thrombocytosis. And again, that kind of, when you see that, you often think, especially in a 38-year-old with kind of neck swelling in the story, that is making us very concerned of infection. Oftentimes when it gets that high, I often also in the back of my mind think about abscesses and whether there is an abscess hiding. So thankfully we got the imaging that we can go through in a bit. In terms of the PCO2 that is 50s, that's elevated, especially with someone who we have taken care of a lot of patients who have chronic a pulmonary disease like COPD who live in the 50s, but in someone who doesn't have underlying disease, 50s are elevated, and that's something to monitor both her mental status and her gases as you're treating the underlying etiology. So I'm really grateful that the ENT was involved. I would have anesthesia, I keep a close eye on him. I would be trending that gas and keeping a really close eye on her mental status, because if she's getting more hypercarbic, that would be an indication. And this is someone that for the meantime, just keeping her NPO would be good. In terms of what I would be doing, I know Maddie mentioned Antibiotics, and I think Unison is a great choice here if you're worried about anything oropharyngeal or neck, thinking about what bugs live there. Unison provides a great coverage, and just given degree of how sick she is, staph and strep coverage, like a MRSA coverage, makes a really good sense to me as well. So I would have thought like bank Unison as well, and then and then okay, I'm going to pause and then have Jack comment on the imaging.
Oh, keep going. Keep going.
No.
All right. I will talk briefly about the imaging. So I think there's two things that are interesting here. One is this thrombosis of the left internal jugular vein, and then also the supraglottic mass, as opposed to the absence of what seems like a focal drainable abscess. And I think that sort of the degree of mass-like inflammation in that area, I think reflects just how intensely inflammatory an infected clot is, right? What we're not seeing is a soft, and I may be eating my words here, right? As this evolves, it may evolve into a soft tissue abscess, but at this point in time, it's more of a mass-like problem with associated internal jugular vein thrombosis. I think one hypothesis is, masses can be incredibly inflammatory, right? And we're making the assumption that this is that this is an infectious process thus far. And I think that is a sound and well-reasoned assumption to make, right? Fevers and the acuity of the inflammatory syndrome prioritizes infection. But Sharmin took us through a brilliant framework for a neck mass overall, and some of those can be infectious in nature, but there's certainly other things that can be mass-like, non-infectious in nature, and cause fevers, whether that's cancer, underlying autoimmune disease, or something like an endocrinopathy. And so I think seeing this, right, we have to be open to the fact that this is a non-infectious process, but put all of our cognitive weight behind an infectious process, both because of the base rate of disease and then the acute morbidity. So that I think is how the mass is shaping up in my mind. And then the associated internal jugular vein thrombus, I think makes us, how do I say this? It brings up two key dilemmas in this case. One is the fact that this person potentially has an infected blood clot, which is sort of like endocarditis, right? There is bacteria within the bloodstream that's stuck to something in the bloodstream, and there can be major complications that develop from that, right? In left-sided endocarditis, we worry about arterial circulation embolic phenomenon. In a septic thrombophlebitis of the venous system, we worry about septic emboli, particularly to the lungs. And so we don't hear that there are septic pulmonary emboli or things like lung abscesses, but those are certainly feared complications of this syndrome of again, what seems to be septic thrombophlebitis of the internal jugular vein. The other thing is that when we see these imaging findings, blood clot in the internal jugular vein, all of our cognitive energy right now is focused on the neck and the airway, and that's where it should be. But once we get the neck and the airway under control, we owe it to our patient to turn our attention to other places in the body, because septic thrombophlebitis of the internal jugular vein, the most common cause of the most common location of embolic phenomena is in the lungs with septic pulmonary emboli and lung abscesses. But the second most common location for embolic events is actually in the large joints. And so this would be a space where it would be helpful for us to examine the shoulders, examine the elbows, examine the hips, examine the knees, examine the ankles, and tap down her vertebral spine to make sure we're not missing other distant metastatic foci of infection that could be set up here. And then the last thing is to comment on the negative blood cultures. If this is indeed septic thrombophlebitis of the internal jugular vein, right? I think I saw something in the chat or many people mentioning Lemire syndrome. The microbiology of Lemire syndrome is oftentimes anaerobic organisms like Fusobacterium species. We can see our sort of characteristic gram-positive cocci in there, and then also things like the Bacteroides species, but it's usually things like Fusobacterium, Bacteroides, and then sometimes things like staph or strep pyogenes or some of the strep anginosus organisms. And of the things on that list, most of those things are not the most rapidly growing or easily grown things on blood cultures. So blood cultures can absolutely be negative despite an infected thrombus within the jugular vein. And if there's any sort of medical history buffs out there who I think that there's some people here who like this stuff, I encourage you all to check out the article from 1936, which is the original description of of Lemire syndrome. It's called On Certain Septicemias Due to Anaerobic Organisms. And it is a really interesting read and an entertaining read for those who want to see what case descriptions were like almost 100 years ago. But yeah, I will stop there and kick it back to you, Sharmin.
Yeah, no, I love that discussion, Jack. And yeah, for sure, like, the the thrombosis and the, especially if it's thrombophlebitis and infection of it, really raises concern for lineal disease. With her like photos and imaging, the one thing that was like, I was thinking whether this is like looping angina type as well, that, I think like negative blood cultures, yes, I would repeat those, by the way. Again, like I think it also depends on where you catch them. Sensitive and specificity varies as well. So, but that's another thing that came to my mind, was that whether this is all kind of a looping angina as well. But I think you can say a couple of different things. I'm glad she's on the right antibiotics. And I'm really, really would love to hear how Maddie and the team put it together.
All right, amazing discussion, Jack and Sharmin. So yeah, just to kind of wrap up, so based off of these imaging findings and her clinical picture, she was diagnosed with Lemire syndrome. There was this thought of like, is there Ludwig's angina as well? But per ENT, they thought clinically this was not representing Ludwig's angina. And in terms of Lemire syndrome, so for the source was favored to be either a periodontal infection, given the history of poor dentition, or pharyngitis that she had 1 week prior. It was unclear which of those or both were contributing to this. I'm trying to see what else I can talk about. So I got involved with the infectious disease team, and by the time I saw her, she was actually never intubated, but she was in the ICU and her mentation improved. She was chatting to us, but was still really bothered by the mass. When I was kind of reviewing her records, her course was actually complicated by an abscess formation that formed in that same region that was like 3 by 6.8 centimeters. So she ultimately underwent drainage for that, and she was treated for unison for a total of 4 weeks for treatment of septic thrombophlebitis. And I saw that she had a follow-up appointment with ENT and is feeling much better and no longer has the mass and is doing well. But it was a really awesome case to kind of read about Lemire syndrome. And it was interesting that, as Jack talked about, the bug you think of is Fusobacterium, but the blood cultures were always negative. The repeat blood cultures were negative. But I kind of learned about the pathophysiology of Lemire syndrome, and you have this like primary infection, whether it was from the like oral cavity or from pharyngitis. And then you have this local invasion into the internal jugular vein, and then kind of development of the septic thrombophlebitis. So it was just a very interesting case to be a part of, and learned a lot hearing your discussion.
Thanks so much, Maddie. Thank you for bringing this case. Yeah, that was a really fun one to get to think through and talk through. And yeah, Mark, I'm excited to hear the teaching points that you have for us after this one.
Yeah, such a great case, guys. Thank you for sharing. So we started off. So we had this 38-year-old woman with left-sided neck swelling, and Sharmin kind of went through the differential diagnosis for neck masses, and we took this beautiful anatomic approach, kind of first thinking of, no misdiagnoses like abscesses, and then thinking about, what else is in the neck, right? We have lymph nodes, so lymphadenopathy can cause a neck mass. We have the thyroid, so thinking about things like thyroid cancer. We also have the salivary gland, so we can think about salivary gland enlargement or stones. And then we also have our vascular supply as well. So thinking about like IJ thromboses, which ended up being the final diagnosis in this case, and then also the parathyroid glands. And then Jack kind of layered on, how does the recent sore throat really change our reasoning in this case? Thyroiditis can cause a sore throat, but we thought, what are some complications of pharyngitis? So we thought of two big complications. First being deep neck space infections, and then also airway obstructions. So there's red flags for each of these. So for deep neck space infections, if the patient has unilateral disease, if they have swelling in the oropharyngeal cavity, if they have trismus, if they have severe pain, your antennas should be up for a deep neck space infection. And then for airway obstruction, the red flags are drooling, stridor, a hot potato voice, which was demonstrated by Jack very nicely. And then we also thought, how can a throat problem lead to shortness of breath, right? We thought about, there's really three main mechanisms for that. There's airway obstruction, there's vascular through the IJ thrombus, and then also extension into the mediastinum. We kind of talked about things like Ludwig's angina. Sharmin told us that, in this situation where you should really treat before we diagnose, we always think about our ABCs, our airway, our breathing and circulation. In this case, this patient was rather sick. They were hypoxemic, they were drooling, they had a poor mental status. So always getting a blood glass to see if someone is retaining CO2 or is profoundly hypoxemic, and then getting your anesthesia and ENT colleagues in just in case you need an early intubation. It's always important to remember that, a normal pulmonary exam does not rule out a parenchymal lung problem. That's why, we very commonly get imaging and do things like POCUS. So it's helpful if it's positive, but not always helpful if it's negative. Always when you have a white count that's as high as 30,000, think about things that can hide, like neck, like abscesses. Remembering that a PCO2 of 50 is not normal. We see this commonly in our patients with obstructive lung disease, but if we have a patient, a 38-year-old woman without obstructive lung disease, this could be an early sign that, her mental status is getting worse and she's retaining CO2 and hypoventilating. And then we learned that masses could be incredibly inflammatory. We went back to our favorite mnemonic, the IMAID mnemonic, thinking about infection, cancer, autoimmune, but always prioritizing infection, really giving its base rate and morbidity. And then we kind of landed on, what are some of the complications of septic internal jugular thrombophlebitis? Most commonly, it will go to the lungs and we'll cause pulmonary septic emboli and lung abscesses. But it's always important to do a good joint exam because it actually can embolize to the large joints like the shoulders, the hips, and the vertebrae. And then we learned about the microbiology of Lemire syndrome. Thinking about anaerobes, Fusobacterium, staph, strep, Bacteroides, and to not be reassured by negative blood cultures and always getting repeat blood cultures if you're concerned. And then Maddie beautifully went over the pathophysiology of Lemire syndrome, kind of starting with the primary infection in the oropharynx, local invasion into the internal jugular vein, and then the septic emboli phenomenon. Thanks for sharing, everyone, and great teaching today.
Mark, that was brilliant. Thank you for elevating an already great case by that amazing teaching points. Mariana, thank you so much for scribing. Maddie, what a great case. Thank you for presenting. And Jack, so good to discuss with you. And thanks all for all thank you for all the wonderful thoughts in the chat as well. We'll see you tomorrow. Bye.
Bye.